Good afternoon, colleagues. Today I have prepared a presentation titled The Science of Blood Products. In South Africa, a blood transfusion takes place every 48 seconds. We need a minimum of 810,000 units of blood annually to meet the demand, and currently the South African National Blood Service, a non-profit organization that provides human blood for transfusion in South Africa, has a donor base of only 432,000. This is less than 1% of our population. Despite efforts to ensure the safety, blood transfusions are unfortunately associated with some risks. The Serious Hazards of Transfusion, or SHOT scheme in the UK, estimated that in 2014, the risk of transfusion-related death was 5.6 per million blood components issued, and the risk of transfusion-related major morbidity was 63.5 per million blood components issued. The number of deaths slightly improved if the cases caused by the delay in transfusion was removed. They further found that the most common cause for death associated with transfusion was associated with fluid overload. A brief history of blood donation. It all started in 1628, when it was discovered that blood circulated through the body. In 1965, the first successful blood transfusion was performed in dogs. It was only in 1818 that the first successful blood transfusion was done in humans for the treatment of postpartum hemorrhage. Blood groups were subsequently discovered in the beginning of the 1900s, and typing and cross-matching was attempted in 1907. In 1914, storage of blood was allowed by the use of sodium citrate, and in 1932, the first blood bank was established in the United States. The RH group was later discovered, and the process of apheresis was discovered allowing the extraction of single blood products. And lastly, it was only in 1985 that HIV screening of donated blood was done. A quick look at the process of blood donation. The process starts with the donor completing a questionnaire. This assesses the health and lifestyle of the donor. This information is further clarified and confirmed by a one-on-one interview with the nurse. This is followed by a quick blood pressure and hemoglobin test. The patient is then assessed, and if the patient meets the criteria, the blood is donated. This process can be repeated every 56 days. Of all the blood collected, only 5% is stored in an unmodified state. If transfused to a patient in this state, it is known as a whole blood transfusion. The remaining blood is centrifuged and divided into red cell concentrates, fresh frozen plasma, cryoprecipitates, and platelet concentrates. Plasma fractionation further provides the opportunity to derive specific factor concentrates and intravenous immune globulin. Once blood is collected, the following procedures can be done to ensure its safety. Screening for infections like HIV, hepatitis B and C, and syphilis. Blood typing and screening. This is essential in the prevention of hemolytic transfusion reactions. Leukodepletion. This reduces the number of white blood cells, thereby reducing febrile reactions, HLA sensitization, and CMV transmission. Bacterial contamination testing of platelets, and this is to avoid septic transfusion reactions. Plasma reduction or washing reduces the risk of allergic transfusion reactions of the effects of incompatible ABO antibodies. And gamma radiation reduces the risk of transfusion-associated graft versus host disease. So who needs it? What are the indications for a blood transfusion? Broadly speaking, blood transfusions are given to increase hemoglobin and oxygenation of tissues, to maintain adequate blood volume and avoid ischemia and hypovolemic shock, and to reconstitute platelets, coagulation factors, and other plasma proteins to a functional status. Packed red cells. So red cell concentrates are prepared from whole blood by removing about 250 milliliters of plasma. 1 unit of red blood cells should increase levels of hemoglobin by 1 gram per deciliter and the hematocrit by 3%. Packed red cells are filtered to reduce leukocytes before storage, which limits febrile non-hemolytic transfusion reactions and are considered cytomegalovirus safe. Stored red cells are metabolically active, and this metabolic activity contributes to a number of biochemical and structural changes. Collectively, these are known as the red blood cell storage lesion. An increasing number of changes have been documented that could potentially affect cell viability. These include depletion of ATP, membrane changes, including the formation of microvesicles and microparticles, increased oxidative damage to lipids and proteins, loss of deformability, which leads to impairment of flow in microvasculature. Furthermore, there are decreases in nitric oxide. Now, nitric oxide acts as a physiological vasodilator that is regulated by several potential mechanisms. This may lead to vasoconstriction, oxidative stress, and possible tissue and organ damage. There is also a reduction in 2,3-bisphosphoglycerate. Now, red cell 2,3-bisphosphoglycerate increases or can increase oxygen delivery to the tissues by shifting the oxyhemoglobin dissociation curve to the right. If it is reduced, it has the opposite effect. However, it is uncertain whether this abnormality is physiologically important, even in critically ill patients. And if it were important, the 2,3-bisphosphoglycerate concentration in the transfused cells returns to normal within 6 to 24 hours of transfusion, resulting in normalization of the oxygen release. Lastly, there is potassium leakage from cells. The potassium concentration in the supernatant of stored red blood cell units increased by approximately 1 milliequivalent per liter per day due to passive leakage out of red cells. This leaked potassium is not actively transported back into the red cells because the red cell membrane, ATPase, is inactive during refrigeration. Thus, while the initial concentration of extracellular potassium in a red blood cell unit is approximately 2 to 5 milliequivalents per liter, it rises to levels of 45 to 60 milliequivalents per liter at the end of storage. And in irradiated red blood cells, the potassium concentration is higher on any given day, and the peak level at the end of 42-day storage is approximately 70 to 90 milliequivalents. However, despite this phenomenon, the risk of hyperkalemia from transfusion is rare in adults because the volume of extracellular component of packed red cells is small. The potential for clinically significant hyperkalemia is greatest in the settings of severe trauma or massive transfusion, when there is impaired renal function, or in the transfusion of infants or newborns. As we know, red blood cells carry oxygen to cells, and anemia reduces the oxygen capacity of blood. When this occurs, the body has the ability to compensate by increasing cardiac output and by increased extraction of oxygen by end organs. This allows us to tolerate anemia down to low levels of hemoglobin. Packed red cells are therefore used to replace blood lost during hemorrhage or to increase a low hemoglobin concentration occurring for other reasons, for example, bone marrow failure or hemolysis. But at what hemoglobin concentration threshold should a transfusion be given? Previously, transfusions were given much more liberally. However, following the publication of numerous studies, a more restrictive transfusion threshold policy has been adopted. However, different thresholds and targets are still used in patients with massive hemorrhage and acute coronary syndrome. The National Clinical Guidance Centre in the UK published these recommendations following an extensive literature review. They recommend transfusion in patients with a hemoglobin of less than 7 and a target of a hemoglobin of 7 to 9 post-transfusion. These thresholds should be increased to 8 and 8 to 10 respectively in patients with acute coronary syndrome. And individual thresholds should be made for patients with chronic anemia. Platelets. As we know, platelets are involved in hemostasis. Platelet concentrates are prepared by blood services from whole blood donations or by apheresis of single donors. Platelet transfusions are used to treat and prevent bleeding in patients with thrombocytopenia or platelet dysfunction. The majority of platelet transfusions are administered to patients with primary hematological disorders, but also commonly used in other clinical scenarios such as critical care and major hemorrhage. The National Clinical Guidance Centre in the UK recommends that platelet transfusion should be offered to patients with thrombocytopenia who have clinically significant bleeding, at least a WHO grade 2, and a platelet count below 30. They also recommend to use a higher platelet threshold with a maximum of 100 platelets for patients with thrombocytopenia and severe bleeding, WHO grades 3 and 4, or bleeding in critical sites such as the central nervous system, which includes the eyes. They further recommend the use of prophylactic platelet transfusions to raise the platelet count above 50 per litre in patients who are having invasive procedures or surgery, and even a higher threshold for patients with a high risk of bleeding who are having invasive procedures or surgery. They do, however, recommend that prophylactic platelets should not be used in patients with chronic bone marrow failure, autoimmune thrombocytopenia, heparin-induced thrombocytopenia, or thrombotic thrombocytic purpura. Fresh frozen plasma. FFPs is either produced from whole blood or obtained by apheresis. It is subsequently rapidly frozen to maintain the activity of labile coagulation factors. FFPs can be stored at minus 25 degrees or below for up to 36 months, with rapid thawing at 37 degrees when needed. After thawing, FFPs should be transfused as soon as possible, but if delay is unavoidable, it can be stored for up to 4 hours at 22 degrees or 24 hours if stored at 4.2 degrees. The National Clinical Guidance Centre in the UK recommends that fresh frozen plasma should be transfused in patients with clinically significant bleeding, but without hemorrhage if they have abnormal coagulation test results. For example, the prothrombin time ratio is active or activated partial thromboplastin time ratio is above 1.5. And they recommend not to offer fresh frozen plasma transfusions to correct abnormal coagulation in patients who are not bleeding, unless they are having invasive procedures or surgery with a risk of clinically significant bleeding. Cryoprecipitate. Cryoprecipitate is prepared from the cryoglobulin fraction obtained by thawing frozen plasma. After removal of the supernatant, the precipitate is refrozen in approximately 30 moles of plasma, and it contains factor 8C, von Willebrand factor, fibrinogen, fibronectin, factor 8. This can be stored at minus 25 degrees or below for up to 36 months. After thawing, it should be infused as soon as possible, though it can be stored at ambient temperature for up to 4 hours. Cryoprecipitate is used as a source of fibrinogen in acquired hypofibrinogemia, which may be seen, for example, with major hemorrhage or with disseminated intravascular coagulation. The National Clinical Guidance Centre in the UK recommends cryoprecipitate transfusions for patients without major hemorrhage who have clinically significant bleeding and a fibrinogen level below 1.5 gram per litre, and not to offer cryoprecipitate transfusions to correct the fibrinogen level in patients who are not bleeding and who are not having invasive procedures or surgery with a risk of clinically significant bleeding. They recommend prophylactic cryoprecipitate transfusions for patients with a fibrinogen level below 1 gram per litre who are having invasive procedures or surgery with a risk of clinically significant bleeding. Are there some alternatives for patients having surgery? So as we know, preoperative anemia is associated with increased post-operative morbidity and mortality, as well as an increased transfusion requirement. The commonest cause of preoperative anemia are iron deficiency, where the body iron stores and serum ferritin are reduced, and functional iron deficiency, which is either caused by infection, inflammation, or malignant disease. In these cases, there is insufficient iron incorporation into erythroid precursors in the face of apparently adequate body iron stores, together with a serum ferritin value within normal limits. As we all know very well, oral iron is used in the treatment of iron deficiency anemia. However, compliance with oral iron may be poor due to side effects, including nausea, diarrhea, constipation, and therefore intravenous iron is an alternative when oral iron is poorly tolerated, or in clinical situations where there is functional iron deficiency. Erythropoietin is the hormone which stimulates erythropoiesis, and recombinant erythropoietin is a further option for treating preoperative anemia. As noted before, transfusions come with various risks, and the complications can be broadly grouped into transfusion reactions, citrate toxicity, hyperkalemia, and infections. Transfusion reactions can further be divided into acute and delayed reactions. The acute reactions include febrile non-hemolytic reactions, acute hemolytic reactions, allergic or anaphylactic reactions, transfusion-related acute lung injury, volume overload, urticaria, and sepsis. The delayed reactions include delayed hemolysis, thrombocytopenia, and graft versus host disease. Acute transfusion reactions range from bothersome, yet clinically benign, to life-threatening reactions. The nature of the reaction may not be immediately apparent, because many reactions begin with non-specific symptoms, such as fever or chills. In addition, patients receiving transfusions often have complex underlying clinical conditions, and the symptoms of which may mimic a transfusion reaction. Febrile non-hemolytic reactions are the most common reaction. They occur in approximately 0.1 to 1% of transfusions. This reaction is more likely in children than adults, occurs more often in platelets derived from plasma, and least likely with plasma transfusions, and it occurs less likely if the product has undergone leukoreduction. Febrile non-hemolytic transfusion reactions are commonly caused by cytokines that are generated and accumulate during the storage of blood components. They typically present with fever, an increase of 1 to 2 degrees Celsius, occasionally severe rigors, and sometimes mild dyspnea, 1 to 6 hours after initiation of transfusion. A temperature increase of less than 1 degree is not considered clinically significant, while an increase of more than 2 degrees is more suggestive of an acute hemolytic or septic transfusion reaction. It is a benign reaction, causing no long-lasting sequelae, but they are uncomfortable and sometimes frightening to the patient. However, since fever may be the sign of an acute hemolytic transfusion reaction or infection, febrile non-hemolytic transfusion reactions require action on the part of the clinical team. This typically involves the following: stopping the transfusion, administration of antipyretics if the fever is bothersome to the patient, evaluation for other causes of fever, which include more serious and potentially life-threatening transfusion reactions, as well as non-transfusion related infection or fever. TRALI, or transfusion-related acute lung injury. The generally accepted theory for TRALI's pathogenesis is that it occurs via a two-hit mechanism. Firstly, there is neutrophil sequestration and priming. This occurs in the lung microvasculature due to recipient factors such as endothelial injury. It refers to the shifting of neutrophils to a state where they will respond to an otherwise innocuous or weak signal. Generally, these events are coupled and exist prior to the transfusion. The second hit is neutrophil activation that leads to the release of cytokines, reactive oxygen species, oxidases, and proteases. that damage the pulmonary capillary endothelium. This damage causes inflammatory, non-hydrostatic pulmonary edema. Transfused factors responsible for host neutrophil activation can include antibodies in the blood component directed against recipient antigens, or soluble factors such as bioactive lipids that can activate neutrophils. Donor anti-leukocyte antibodies can bind to antigens or recipient neutrophils, or possibly to other cells, such as monocytes or pulmonary endothelial cells. This is referred to by some authors as immune TRALE. Bioactive lipids and other soluble factors in the transfused blood component can act as biological response modifiers. TRALE resulting from these non-antibody biological response modifiers is sometimes referred to as non-immune TRALE. The characteristic clinical presentation of TRALE is the sudden onset of hypoxemic respiratory insufficiency during or shortly after the transfusion of a blood product. Symptoms may be delayed as long as 6 hours, but usually begin within 1 to 2 hours of initiating the blood component infusion. Indeed, the majority of cases occur within minutes of initiating a transfusion. A number of additional signs and symptoms associated with non-cardiogenic pulmonary edema and inflammation have also been reported. These include hypoxemia, pulmonary infiltrates on chest radiography, if previously infiltrated, pink frothy airway secretions from the endotracheal tube, fever, hypertension, and cyanosis. The revised criteria of TRALE from 2019 is as follows. They divided in 2 types, type 1 and type 2. Type 1 is when there are no risk factors of ARDS plus acute onset hypoxemia with SATs less than 90% on room air, clear evidence of bilateral pulmonary edema on imaging, no evidence of left atrial hypertension, or if left atrial hypertension is present, it's judged not to be the main contributor to the hypoxemia. The onset is during or within 6 hours of the transfusion, and there is no temporal relationship to an alternative risk factor for ARDS. Type 2 TRALE is defined as patients that have risk factors for ARDS, but has not been diagnosed. They then have deterioration, which is judged to be due to the transfusion, based on the following: that the findings described in categories A and B of TRALE type 1 are present, and the patient had stable respiratory status in the 12 hours preceding transfusion. In the setting of transfusion, the diagnosis of ARDS can be made in patients that have risk factors and when the deterioration is not due to the transfusion, but as a consequence of the already present risk factors. And this is based on if the patient has onset of ARDS within 6 hours after transfusion, but the respiratory status was deteriorating in the 12 hours before transfusion. Or there was existing ARDS that further deteriorated after transfusion, where the respiratory status was already deteriorating in the 12 hours before transfusion. Another entity known as TRALE, transfusion-associated circulatory overload cannot be distinguished, is used when TRALE cannot be distinguished from transfusion-associated circulatory overload, or when both conditions occur simultaneously. Transfusion-associated dyspnea can be diagnosed when pulmonary edema occurs greater than 6 hours after the transfusion and is clinically suspicious for temporal association with transfusion. Treatment includes stopping the transfusion, alerting the blood bank, and then giving adequate supportive care, with most requiring intubation and mechanical ventilation. Hemodynamic support should be given with fluid resuscitation and vasopressors, as patients often present with hypervolemia. However, caution should be taken with early empiric administration of diuretic therapy, as it may result in hypertension in those who are initially hemodynamically stable. However, for patients with sustained hypoxemia and demonstrated hemodynamic stability, administration of diuretic therapy may be an acceptable intervention. Steroids namely intravenous corticosteroids, have been extensively studied in the setting of ARDS, with mixed results. In regards to Charlie, there are isolated case reports supporting high-dose corticosteroids in the treatment of the syndrome. However, the efficacy of corticosteroids has not been tested in prospective clinical studies, and the limited anecdotal evidence is unconvincing. Thus, the routine use of corticosteroids when Charlie is suspected is not recommended. Patients who recover from Charlie do not appear to be at risk or at increased risk for recurrent episodes following transfusions from other donors. Survivors of Charlie can receive additional blood products in the future, and transfusion of needed blood products should not be withheld. Importantly, however, individuals should not receive plasma containing blood products from the implicated donor. The majority of patients who develop Charlie will require admission to an intensive care unit and ventilator support for approximately 3 to 10 days. In contrast, milder cases of Charlie and or possible Charlie transfused ARDS may go undiagnosed or unreported. Although limited information is available, it appears that most survivors will recover to their baseline pulmonary function. Transfusion-associated circulatory overload. Transfusion-associated circulatory overload is a form of circulatory volume overload that can occur in any individual and with transfusion of any blood component. However, the volume of transfused correlates with the risk of developing it, making it less likely with cryoprecipitate than with fresh frozen plasma. Again, a two-hit mechanism is suspected in its pathophysiology. The first hit being volume incompliance. This can be from cardiac or kidney disease, and the second hit being a blood transfusion. Patient risk factors include pre-existing cardiac and possibly renal dysfunction, a small stature, low body weight, extremes of age, and hypoalbuminemia. It should be considered in any patient who has respiratory distress or hypertension during or within 6 to 12 hours of completing a transfusion. The typical presentation of transfusion-associated circulatory overload includes respiratory distress, namely dyspnea or thopnea, in a patient with known or unknown underlying heart failure who is receiving a transfusion, especially in the setting of a positive fluid balance in the intensive care unit. Findings on examination may include hypoxia and or hypertension, tachycardia, a wide pulse pressure, and or jugular venous distension. The cardiac examination may show an S3 heart sound. The lung examination may often reveal rales and or wheezing. Patients are managed with supportive care and diuresis, similar to the treatment of cardiogenic pulmonary edema from other causes. When comparing Charlie with transfusion-associated circulatory overload, these are the specific distinguishing factors. However, these conditions can occur concurrently and is not always clearly distinguishable. In Charlie, a low to normal blood pressure versus a normal to high blood pressure can be seen in Tucker. The body temperature may be normal or slightly elevated in Charlie. Charlie may not show vascular congestion, however, Tucker will show vascular congestion and a pleural effusion. The left ventricular ejection fraction would be normal in Charlie, and they would inconsistently respond to diuretics. The edematous fluid in a Charlie is a transudate and an exudate in a transfusion-associated circulatory overload. Anaphylactic reactions. Anaphylaxis results from sudden, typically massive, systemic release of mediators such as histamine and tryptase by mast cells and basophils, typically in response to an IgE-mediated or sometimes IgG-mediated immune reaction. Anaphylaxis can occur with transfusion of most blood products. However, these reactions are not seen with plasma derivatives, namely albumin, purified clotting factors. Typically, the reaction occurs because the transfused product contains a substance to which the recipient is allergic. The converse has also been reported. In other words, the reaction occurs when the transfused product contains IgE that reacts with the substance in the recipient. These patients typically present within a few seconds to a few minutes following initiation of transfusion. The patient may experience shock, hypertension, angioedema, respiratory distress, and wheezing. These may or may not be preceded or accompanied by symptoms commonly described in urticarial transfusion reactions. The diagnosis of an anaphylactic reaction is made clinically based on the timing of the reaction, the rapid progression to potentially life-threatening symptomatology, and rapid response to therapy. Treatment of anaphylaxis involves the immediate cessation of transfusion, the administration of adrenaline, the resuscitation of hypertensive patients with intravenous fluids, or additional vasopressors like dopamine, and airway maintenance and ensuring oxygenation. Hemolytic reactions. Hemolytic reactions are due to immune-mediated red blood cell destruction. Acute reactions occur during or within 24 hours after a transfusion, and delayed reactions occurs days to weeks after the transfusion. Hemolysis can be intravascular, releasing free hemoglobin into the circulation, or extravascular, resulting in removal of red blood cells by the reticular endothelial system. Acute hemolytic reactions are associated with rapid intravascular hemolysis, which can lead to acute renal failure, disseminated intravascular coagulation, and hemodynamic collapse. Typical symptoms and findings include fever, chills, back or chest pain, and pink-red serum, plasma or urine. Although the full classic triad of fever, flank pain, and red urine is rarely seen. Most commonly seen in the setting of ABO blood group incompatibility due to a clerical or procedural error, in other words, transfusion of the wrong product. Delayed reactions are typically gradual and less severe. Sometimes they are clinically silent. Laboratory findings may include a mild increase in anemia or a failure of the hemoglobin to increase as expected after transfusion, and evidence of extravascular hemolysis, which may include spherocytes on the peripheral blood smear. They generally do not require any treatment except for future avoidance of transfusions containing the implicated red blood cell antigen. So what to do? One sees a suspected acute transfusion reaction. Firstly, stop the transfusion, establish and maintain intravascular access, confirm that the correct product is for the patient, assess the patient for fever, their cardiovascular status, respiratory status, and the presence of urticaria or angioedema. If there is no fever and there is respiratory distress, a transfusion-associated circulatory overload is suspected. One should do a chest X-ray and check the oxygenation status. And supportive evidence would be hypoxia, an infiltrate on the chest X-ray, a response to diuresis, hypertension, high cardiac filling pressures, cardiac history, older age, and a larger infusion volume. If there is fever and chills, respiratory distress, and hypertension, TRALE is suspected. Again, chest X-ray and oxygenation status is inspected, and supporting evidence would include hypoxia and infiltrate on the chest X-ray, pink frothy airway secretions, transient leukopenia, and the onset within 6 hours of the transfusion. If there are fever, chills, but the patient is otherwise asymptomatic, febrile non-hemolytic transfusion reaction is suspected. Supportive evidence needs to be found to exclude other causes. If there is fever and chills, hypertension, flank, back pain, and bleeding, a hemolytic reaction should be suspected. A Coombs test, a full blood count, and a urine dipstick should be done. And supportive evidence include hemoglobinemia, positive Coombs, low haptoglobin, high LDH and bilirubin, DIC, and the discovery of a clerical error. If there is fever and chills and maybe hypertension, sepsis should be suspected. A positive gland stain and culture, visible cloudy product precipitate, and more commonly seen with platelets would support the diagnosis. And lastly, if there's urticaria or pruritus, bronchospasm, angioedema or hypertension, an anaphylactic reaction should be suspected. Supporting this diagnosis would be wheezing, angioedema, hypertension, and a low IgA level or anti-IgA. A massive blood transfusion. These are historically defined as a replacement by transfusion of 10 units of red cells in 24 hours. However, alternative definitions such as 3 units or 3 blood cells over 1 hour or any 4 blood components in 3 minutes are more sensitive in identifying patients needing rapid issue of blood products for uncontrolled hemorrhage. The management of the patient who is being massively transfused requires careful and ongoing consideration of a number of complex physiological relationships. The primary concerns are maintaining cardiac output, oxygen carrying capacity, and hemostatic potential. Cardiac output is maintained with crystalloid volume expanders, and the oxygen carrying capacity is increased by administration of blood products. However, maintaining the hemostatic potential is more complex. Coagulopathy develops due to activation and consumption of coagulation factors secondary to tissue trauma, or reduced activity of coagulation factors from prolonged shock, hypoxia, hypothermia, or failure to clear activation peptides that act as competitive inhibitors. The severe end of the spectrum is DIC, and this is diagnosed when there is microvascular oozing, prolongation of the prothrombin time, and a PTT in excess of that expected by dilution. Significant thrombocytopenia, low fibrinogen levels, and increased levels of D-dimer. Even if coagulation parameters are normal before blood is replaced, coagulation abnormalities may be induced by the dilutional effects of blood replacement on coagulation proteins and the platelet count. Furthermore, both acidosis and hypothermia interfere with the normal functioning of the coagulation system. Acidosis or excess proton specifically interferes with the assembly of coagulation factor complexes. The resulting delayed production and reduced concentrations of generated thrombin lead to delayed fibrin production, altered fibrin structure, and increased susceptibility to fibrinolysis. Hyperthermia reduces the enzymatic activity of plasma coagulation proteins, but has a greater effect by preventing the activation of platelets via traction on the glycoprotein complex by von Willebrand factor. The replacement of blood loss with red cells and crystalloid volume expander will result in gradual dilution of plasma clotting proteins. This will lead to prolongation of the prothrombin time and the activated partial thromboplastin time. A similar dilutional effect on the platelet concentration can be seen with massive transfusion. In an adult, each 10 to 12 units of transfused red blood cells are associated with a 50% fall in the platelet count. Thus, significant thrombocytopenia can be seen after 10 to 20 units of blood, with platelet counts below 50,000. For replacement therapy in this setting, 6 units of whole blood derived platelets or 1 apheresis concentrate should be given to an adult. Each unit should increase the platelet count by 5,000 or 30,000 for a full 6-unit adult dose. In the massively transfused patient, assumptions about possible dilutional effects of red blood cell transfusion should be confirmed by the measurement of the PT, APTT, and platelet count, or a viscoelastic test after the administration of every 5 to 7 units of red cells. Replacement therapy should be based on these parameters rather than using any formula, for example, 1 unit of FFPs for every 4 units of red cells. The thromboelastogram. So thromboelastography, or TEG, assesses the viscoelastic properties of clot formation in fresh or citrated whole blood in real time. The test synthesizes information obtained from multiple coagulation tests such as PT, PTT, thrombin time, fibrinogen level, and platelet count into a single readout. The first parameter looks at the initiation of the fibrin clot formation and represents an abnormality of coagulation factors. It measures the reaction time, or R value, in minutes. It will be increased in hypercoagulable states. The second parameter looks at the interaction between fibrin and platelets. The K value is the time it takes to achieve a 20 mm clot on assay, and the alpha angle represents the rate at which fibrin cross-linking occurs. An increased K time and a decreased alpha angle will point to a reduced fibrinogen level. The third parameter looks at the maximum clot strength. It is measured as the maximal amplitude. A reduction in the maximal amplitude would represent a reduced or dysfunctional platelets. The last parameter looks at clot lysis. The LY30 is a measure of the degradation of a clot after 30 minutes after the maximal amplitude. It will be increased in cases of increased fibrinolysis. Therefore, in cases of increased R time, give FFPs. Increased K time or decreased alpha angle, give cryoprecipitate. Decreased maximal amplitude, give platelets. And lastly, increased LY30, consider giving tranexamic acid. Looking at some of the last complications of massive transfusion, potential of citrate toxicity. So large amounts of citrates are given with massive blood transfusion, and since the blood is anticoagulated with sodium citrate and citric acid, it can lead to a metabolic alkalosis and decline in plasma-free calcium concentration. To prevent hypothermia, a high-capacity commercial blood warmer should be used to warm blood components toward body temperature when more than 3 units are transfused. Rapid transfusion of multiple units of chilled blood may reduce the core temperature abruptly and can lead to cardiac arrhythmias. 6 units of red blood cells at 4 degrees will reduce the body temperature of a 70 kilogram adult by 1 degree. This heat loss can be additive with the evaporative heat loss associated with an open abdomen or other body cavity, which by itself can lead to a 1 degree decrease in core temperature in 40 minutes. Thus, 10 units of cold blood products and an hour of surgery can lead to a 3 degree drop in core temperature and result in hyperthermic coagulopathy. And here are my references. Thank you very much.